Hello, it is Ryan, and we could all use an extra bright spot in our day, couldn't we? Just to make up for things like sitting in traffic, doing the dishes, counting your steps, all the mundane stuff. That is why I'm such a big fan of Chumba Casino. Chumba Casino has all your favorite social casino-style games that you can play for free anytime, anywhere with daily bonuses. That should brighten your day a little. Actually, a lot. So sign up now at ChumbaCasino.com. That's ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.
Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you for being with me today. I hope you find this podcast beneficial. A couple other beneficial things at reallifepharmacology.com. A brand new release of free nursing pharmacology questions. So I've got 21 different categories from cardiovascular to central nervous system and all sorts of different stuff that I've put together. The other free resource is Top 200 Drugs. It's a study guide. Simply an email will get you access to that. The questions, the free nursing pharmacology questions, are available to anyone. Please share with those maybe going through nursing school, taking nursing board exams. I think they're going to be a nice, handy resource to kind of test your skills. So definitely go check out those free resources at reallifepharmacology.com. All right, let's get into the drug of the day today, and that is calcium carbonate. So this is an incredibly common supplement. I feel like 30 to 50% of residents in long-term care and assisted living that I work with take this supplement. It might not be that high, but anecdotally, you will for sure see this almost on a daily basis if you work with older patients particularly, and some with younger patients as well. So, brand name of this, you'll see multiple different brand names as it is available over the counter as a supplement. So there's Tums, there's Maalox, there's Caltrate, and depending upon how it's branded and marketed, it could be or purported to be used for multiple different things. So most often I probably see it used as a supplement for patients at risk for osteoporosis, for example. Other most common situation is antacid use. So if people have a little bit of heartburn, maybe they don't get it that often, they take a Tums or a calcium carbonate to kind of help settle that stomach a little bit. So those are by far the two most common uses that I see calcium carbonate used for. I want to stress the importance of looking at the back of the label. So many products like Maalox, for example, it can have multiple things within that product, and you just got to look at the back and make sure you know exactly what your patients are getting, and obviously educate patients about that as well, to look at the back of the label and make sure we know what they're getting. One other use, it can be used as a phosphate binder. Not something I see very often due to elevations in calcium, which can be problematic. I might discuss that a little bit later on in the podcast here too. But a little bit of background about calcium in general. So with calcium carbonate, 1 gram of calcium carbonate is approximately equivalent to 400 milligrams, or I guess that would be 0.4 grams. So essentially, calcium carbonate is 40% elemental calcium. As a reminder, the kind of recommended dietary intake ranges in the ballpark of 1,000 milligrams to 1,300 milligrams. And that kind of depends upon age, risk factors, and other things like that. But that's kind of the usual target range for most individuals. Another thing to think about is absorption of calcium. This is something that I have written recommendations on previously. If you give large amounts of calcium at one time, and or if that pH of the stomach intestinal area is higher, we may get less absorption of that calcium. So important education point, I think, there to pay attention to if we don't feel like we're getting adequate absorption of calcium, or if we're trying to maximize absorption of calcium. Dosage form, we've got a ton of them. Tablet, suspension, chewable tablets, gummies, all sorts of different flavored products with calcium in it. It tends to give off this chalky type texture and taste. So that's definitely indicative of calcium carbonate, or common with that. Larger doses, I mentioned, getting into a little bit more specifics. Typically, most people are going to say, and I think most of the literature bears this out as well, you're probably only going to be able to absorb in the ballpark of 500 to 600 milligrams of elemental calcium at one time. So pay attention to the dosages that we're given, and that's often why you see calcium spaced out twice a day. That's why we don't just take it all at one time in the day if we are supplementing for a patient. All right, adverse drug reactions. So really well tolerated in general. So it's usually not an issue. You might have some GI upset or something rare associated with the patient, but generally we use Tums to kind of settle the GI tract and settle the stomach a little bit with its antacid type effects, at least acutely. Constipation is one thing that I have seen occasionally with patients, and that's probably going to increase as you increase the amount of calcium carbonate supplement that you're giving. Possibly some bloating, things like that. This theory of rebound acidity has been reported and seen in the literature as well, where maybe patients take their dose of calcium carbonate, and that tells your body, like, hey, the pH of the stomach is going up, let's pump out some more acid. And so there is some evidence to kind of show that cycling a little bit. Not something I generally worry about tremendously, but if you've got a patient reporting lots of symptoms and that they kind of keep coming back and cycling and that type of thing, be sure to ask about how much Tums they're taking or calcium carbonate they're taking. And that might be a contributing factor in kind of those fluctuations of symptoms there. And then, of course, the big thing I think as far as monitoring and lab monitoring is potentially checking calcium levels. Not typically done on patients kind of on standard doses of calcium supplement, 500 or 600 milligrams once or twice a day. You're probably not going to have to check calcium levels. The riskier situations, probably as renal function declines, calcium may cause some accumulation, or may accumulate in that setting as well, or at least be more likely to accumulate in that situation. And I'll talk a little bit more about that risk in the drug interactions and other drugs that might contribute to that. So one other thing, electrolyte-wise, other than calcium to think about, is phosphorus. So I mentioned at the start that calcium carbonate does have phosphate binding properties. We generally don't use it as a phosphate binder. You see lots of other agents utilized for various reasons, which I won't delve into that too much. But just keep in mind that calcium carbonate can lower phosphate levels. All right, so one other adverse effect, one other thing to pay attention to is renal stones, particularly calcium oxalate stones. So calcium can be a contributing factor to this risk. So when you've got somebody with a history of renal stones, you definitely want to try to identify what the cause of those stones is, and if calcium is playing a role there, or we think it is, then we've got to go in and assess, see how much calcium they're taking, if they're taking extra supplements, that type of thing. Because again, calcium carbonate is found in a ton of different supplements, from vitamins to antacids to all sorts of different stuff like that. So pay attention to that. That excessive calcium intake or kind of dysregulation in calcium intake could potentially increase that risk for calcium oxalate type stones. And then lastly, touching on monitoring a little bit, obviously if you're using it to manage symptoms of heartburn, you want to look at frequency of use, things like that, and make sure there isn't something bigger going on there if patients are using a product like Tums a lot. Other monitoring, so I mentioned the calcium, I mentioned the phosphorus. We're also probably going to take a peek at renal function, and if you've got a patient who's had worsening renal function over time, we may be at a little more risk of having that calcium go up, particularly if we're taking a significant amount of calcium carbonate. So those are the primary monitoring parameters there. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're taking a pharmacist board certification soon, definitely go check out meded101.com/store. Got a growing list of resources, BCPS content, NAPLEX, ambulatory care, BCM, TMS, geriatrics, lots of test prep materials that will definitely help you prepare to pass your exam. So go check that out, support the sponsor, help keep this podcast free. If you're a nurse, med student, other healthcare professionals, we've got lots of different books, food-drug interactions in primary care, Meded 101 Guide to Nursing Pharmacology. So go check out those resources, support the sponsor, and help this podcast remain free for all to benefit from. All right, let's wrap up with drug interactions, and there are a lot of them, so I'm going to take a little bit of time on this. You wouldn't think necessarily that maybe there's a lot with kind of an over-the-counter type of product that many people take, but there is a substantial number, and it's primarily due to binding interactions. So essentially what calcium does, or calcium carbonate does, is it binds up medications and prevents absorption. So treatment failure is going to be much more likely when we use these medications in combination. And again, I'm talking about orally specifically, and I'm also talking about administering them at or near the same time frame. So first off, with administration, let's talk a little bit about the time frame. So you'll get varying medications that say 2 hours, 4 hours, 6 hours, as far as the separation goes. From my perspective, ideally it is best to separate further. Now, in many polypharmacy patients, that may be difficult to do, but the further away you can get, whether it's 2 hours, 4 hours, 6 hours, from taking calcium with another medication that interacts, the better off we're going to be. So most will say that 2 hours, if you take, let's take bisphosphonates as our example, or levothyroxine. If you take those medications 2 hours before calcium, you're probably going to get most of the absorption. Now, if you take it 4 or 6 hours before, obviously that's going to ensure that we're probably maximizing our absorption altogether there. But generally 2 hours before or 4 to 6 hours after. And again, there are exceptions absolutely to kind of that guidance or that rule. And a lot of it's common sense. So, for instance, levothyroxine, I mentioned that example. If we've got a TSH and we know we're within range and the patient hasn't changed any of their medications recently, I'm probably not going to be too frazzled about it, okay? We've probably compensated for the interaction, encourage the patient probably to continue taking it the way they're taking it, and thyroid function's good, patient's doing well, everything's okay there as long as we maintain consistency. So that's a really important thing to think about, that we can monitor for some medications like levothyroxine. Now you get some of the other ones like antibiotics, for example. So tetracycline derivatives, quinolone antibiotics like ciprofloxacin. There we really want to do our best to try to maximize that separation if at all possible. So ciprofloxacin, let's take that example. We're giving it twice a day. We really want to kind of maximize that separation. And I've had certain instances where maybe a patient's taking calcium carbonate, 500 milligrams, 3 times a day. Well, can we maybe just hold a dose for 5 to 7 days while we get through this antibiotic? So there are some kind of common sense things where nobody's probably going to die if they don't get their calcium for a dose here and there, versus if they don't get a dose of their ciprofloxacin or calcium binds it, we could lead to treatment failure and obviously worsening infection. So really have some common sense with some of these binding interactions. Think about, the timing, the spacing, as well as potentially holding the calcium if it's not really essential or if we don't think it's doing that much for the patient anyway. But here's kind of the list of common ones that I put together. Again, not an all-inclusive list, but bisphosphonates, so your oral bisphosphonates like alendronate, baloxavir antiviral medication, cefuroxime, levothyroxine, tetracycline derivatives, doxycycline probably being the most commonly used in practice, iron, quinolone antibiotics. I mentioned there's numerous HIV medications, so pay attention to that if you know your patient has HIV. Iron, some of the azole antifungals like ketoconazole, itraconazole, and again, there are others that are probably less common than some of the ones I've listed. But again, binding interaction, it's going to reduce concentrations of all these drugs if we give them too close together. One other interaction I wanted to mention is increasing calcium levels. Thiazide or thiazide-like diuretics actually help maintain calcium levels in the body, or they can actually increase calcium levels in the body, which is different from like loop diuretics. So giving calcium, maybe even vitamin D on top of that thiazide diuretic, I have seen situations where that calcium has gone a little bit higher than the upper normal limit there. So pay attention to that, particularly in patients that may be sensitive to rises in calcium levels. And then I have been asked about calcium channel blockers. Wouldn't giving calcium kind of oppose the beneficial effects of lowering blood pressure and the way the drugs work? And I would say in theory, yes, it can. In clinical practice, it's something I have kind of tried to pay attention to. In general, I haven't seen it, and that's anecdotally, and I think the evidence is fairly weak, but there may be some evidence saying, hey, this might impact the blood pressure lowering effect of, let's say, amlodipine a little bit. So clinically relevant, I would put a big question mark on there, but it might be something that you look out for in your patients who are taking calcium and a calcium channel blocker, and just kind of look for that cause and effect type relationship. And if you do happen to notice something when you start calcium and they're on a calcium channel blocker, or you've got a patient not responding to a calcium channel blocker, and we're thinking we're going to drop the blood pressure, might be something to look at, that maybe that extra calcium is kind of blunting that effect of it a little bit. So with that, I think that wraps up the podcast for today. I hope you picked up some clinical practice pearls. If you did, please leave a rating, review on iTunes or wherever you're listening. Support the sponsor, meded101.com/store. Any purchases there go to directly help fund the podcast, and obviously keep it free for all those to benefit going through med school, nursing school, pharmacy school, those that maybe don't have as much disposable income. So appreciate all the support there. If you got any comments, suggestions, mededucation101@gmail.com, or you can find me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. One last plug for the free nursing pharmacology questions on Real Life Pharmacology. That does not require an email, sign up for the mailing list, nothing. Top 200 study guide does require simply just an email. We'll get you access to that, and then we also let you know when we've got new podcast episodes and other things available. So with that, I'm going to sign off. Thank you so much for listening. I hope you have a great rest of your day.
Hey guys, it is Ryan. I'm not sure if you know this about me, but I'm a bit of a fun fanatic when I can. I like to work, but I like fun too. It's a thing. And now the truth is out there. I can tell you about my favorite place to have fun. Chumba Casino. They have hundreds of social casino style games to choose from with new games released each week. You can play for free anytime, anywhere. And each day brings a new chance to collect daily bonuses. So join me in the fun. Sign up now at ChumbaCasino.com.
No purchase necessary. VGW Group. Void where prohibited by law. See terms and conditions. 18+.